In this video, we're covering the very common topic of hip fractures. Now, this is a very simple topic in one way, but also it's something that can be easily failed if you don't stick to the very basic concepts of orthopedic first aid. So for hip fractures, the definition of this would be a proximal femur fracture above the level of the lesser trochanter. So anything below that will be a femoral shaft fracture, and all of that is a very different type of animal. Broadly speaking, from a classification perspective, you as a medical student or a junior doctor would be expected to know whether it's intracapsular or extracapsular. And the reason for this is the blood supply and the implication this has for us in the way we treat it in the future, and also what we will offer the patient with regards to fixing it or replacing it. The incidence is, depending on the information you seek and where you find it, for the UK, it's greater than 75,000 hip fractures a year in the UK. Some reports will say that it's above 90,000 per year as well. But as you can see, it is a huge clinical burden on an annual basis. There's a bimodal distribution. There's high energy in the lower patients, which would be polytrauma, and this talk will not focus on this, as that is not what is generally covered for medical school when it comes to hip fractures. The low energy or fragility fractures in the older patient are what we're focusing on today. The signs would be shortened sometimes and externally rotated sometimes of the lower limb in question. Not always, and that is not a sure sign that if it's not shortened and not externally rotated, that it's not broken. That's not the case. There will generally be a bruise on the outer aspect of the hip over the GT. Associated injuries can be wrist fractures, rib fractures, neck fractures, or facial injuries as well. The symptoms that the patient will report, if they're compos mentis, need to be clarified. Did they fall and break the hip? Or did they feel the hip break and then they fell? So they're a very different type of creature as well. Pre-syncopal events need to be asked directly. Loss of consciousness, mechanical fall, a term that will divide a room generally, and also malignancy history. Is this a cancer deposit, and has that made the bone more fragile? Investigations would be orthopedic specific and patient specific. So you'll need an x-ray. What type of x-rays do you need? You need an AP of the pelvis and a lateral of the hip in question. Patient-specific stuff then would be your normal ECG, chest x-ray, baseline bloods, including full blood count and U&E with a group and save, but not a CRP. You do not need to do one. It costs a lot of money and it doesn't change your management. The treatment is injury dependent, and it goes back to what we mentioned already. Is it intracapsular or extracapsular, and therefore do we fix it or replace it? Then the treatment options, if you're doing well, you would discuss these: cannulated screws, DHS or dynamic hip screw, intramedullary nail, hemi-arthroplasty of the hip, or a total hip replacement. The prognosis for these, you can break them into thirds. 1/3 will die within a year of the injury, 1/3 will not return to their previous level of function, and 1/3 will not return home and will end up staying in a respite home or a nursing home. Extracapsular versus intracapsular. For this one here, you can see this is the femoral head, and the femoral neck itself is sitting below it. On the left-hand side of the screen where the arrows are pointing, it's an intertrochanteric fracture, and therefore it is extracapsular, and you can fix these. The Garden classification is a medical school favourite. We often avoid it in general practice of orthopedics because it's only based on a front two-dimensional view of the AP of the pelvis and AP x-ray. On the red side here, on the left-hand side, you have a DHS and an intramedullary nail, and you can look into those as well and discuss that a bit further, but I think that's well beyond the scope of a medical school exam. And the hemi-arthroplasty versus a total hip replacement on the green or the right-hand side of the screen is a discussion again that we'll cover in the FRCS video in a little while. And this is what we do if you have an intracapsular hip fracture. So just to cover these again, your main stuff would be intracapsular or extracapsular. Look at your polypharmacy, look at the other associated injuries and the other associated symptoms in the lead up to this injury.